Right, thank you everyone. Welcome to this Adults and Health Scrutiny Review Board meeting on Tuesday the 15th, starting at 6 o'clock. Thank you. Do we have any apologies?
One from Andy Smith.
Thank you. We don't have any late items as such, although we have a scheduled report that was delivered late from Robin Dewis, so we will be that is on the agenda for later on. Any declarations of interest? Thank you. Do those who are present accept the minutes of the meeting held on the 20th of April 2021 as a true record of that meeting?
Yeah, I'll accept.
Thank you very much. So we move on very quickly then to our first report, which is improving mental health inpatient facilities in Derby. And that is presented by Andy Harrison from the Derbyshire Healthcare NHS Trust and Mick Burrows from the NHS Derby and Derbyshire CCG.
Shall I make a quick start just to set the scene? My name is Mick Burrows. I'm from Derbyshire CCG, representing the commissioning side of this. This is the second time it's been back to Health and Overview Scrutiny Committee. This represents a significant change in how mental health estates, inpatient estates, are delivered across all of Derbyshire, north and south. It's possibly not that well understood that Derbyshire has a lot of dormitory-based mental health accommodation, and that there's a dormitory eradication policy from the government that's been in place for a couple of 3 years now. Derbyshire is now in a position where we can rapidly look to get some capital funding to start a dormitory eradication programme. Essentially that will give us a significant improvement on estate with individual rooms and ensuite rooms and a much better standard of care. It's part of a whole system approach where we'll be bringing in in-house psychiatric intensive care unit, which we haven't got in Derbyshire yet. That's separate to this particular outline business case, and we'll be bringing in additional estate to help look after women as well who've got more high levels of disturbance. Again, not part of this case. So in terms of does the CCG support this case moving forward? Yes, absolutely. It takes us a long way from where we are now to a higher quality of provision for people with mental health problems who become inpatients. It involves a complete redevelopment in Derby and a complete redevelopment in Chesterfield, and for that reason we support it moving forward. But I'd like to let our colleagues talk to you about the details.
Thank you.
Hi Chair, my name's Andy Harrison from Derbyshire Healthcare, and my colleague Jeff Neild, also from Derbyshire Healthcare. So this is really just a follow-up to the previous information in January. Since January, we have been able to apply for and have set aside a sum of £80 million from the National Dormitory Eradication Fund, which will enable us to replace with new builds our two existing units, the Radbourne unit at the Royal Derby Hospital and the Hartington unit at Chesterfield Hospital. And so the plan is to use that £80 million worth of national funds to develop a new build 54-bed unit on the Kingsway Hospital site, a 4-minute drive, short walk from the existing Radbourne unit. And that will cover, that will provide services for southern Derbyshire, and a 54-bed unit on the Chesterfield Hospital site, which would cover Derbyshire North. The funding that has been set aside, we have to apply for using an outline business case and full business case model, with the restriction that it has to be utilised. It has to be utilised and the buildings built by March 2024, which in national terms is an extremely tight timescale, which is why we're pressing on at some speed with the approvals process for the business cases. The £80 million, as I say, provides two for 2 units, new units of 54 beds each, and that doesn't completely eradicate the dormitory-style wards that we have for acute mental health care. So the Trust will be working with the system to seek approval to utilise local rather than national capital funds to refurbish the existing Radbourne unit once the new unit is provided, to provide the final 34 beds that then keeps the same level of acute mental health care beds across Derbyshire, but completely eradicates dormitories and provides single room ensuite accommodation. In addition, as Mick was just saying, we're also looking to get local support separate to the national business cases to develop a psychiatric intensive care unit, 14 beds on the Kingsway site, and an acute plus 8-bedded acute plus facility for female patients on the Kingsway site, and that is absolutely focused on providing a range of acute mental health services locally, so that patients don't have to be cared for out of county. As it says in the paper, Audrey House on the Kingsway site is a rehab facility that is actually not being used at the moment due to low demand, and we're looking to utilise that as part of the Decant facilities to enable the new builds and the refurb to happen. It's also a potential site for the acute plus facility on the Kingsway site, but that needs to be scoped out, and we'd like, in terms of future updates to Overview and Scrutiny Committee to come back with more information on that. And so in summary, it's a fantastic time-limited opportunity to get national money invested in Derbyshire mental health services. With the additional work that the Trust is doing, we'll be able to provide a significant amount of more intense services through the psychiatric intensive care units and acute plus to stop people going out of county. No beds are lost in the development, and we've had the welcome support engaging with our service user forum Equal in the development of plans to date, and will continue to do that, so that people with lived experience of mental health are actually shaping the design of the buildings where that care will be provided. We're also looking to use a survey during July and August this year to involve members of the public, other stakeholders that have an interest, so that we can get as wide a view as possible to help shape those services. That's really all I wanted to cover, Chair, but just to say, obviously, we will continue to come back to future Overview and Scrutiny Committee meetings to keep you up to date with the views, with the plans, and happy to take any questions.
Right, thank you very much for that. That was very clear. Right, any questions? Councillor Froggatt?
I know you said that there would be no bed losses once you've done it all. As we know, the hospital is crying out for ward, so as Radbourne unit and all this are moving over to Kingsway, will they still be being utilised for mental health until everything's in place? You know, are we going to lose some beds over time until they're all built? And if so, will this impact on how long the waiting list is for the clients? Do you know what I mean? Because you know what they're like.
Yes.
You're moving, so we're going to take this anyway. So there could be a longer wait for people to come in.
Yeah, if you don't mind, I'll pick that question up. We've designed a Decant Program, which starts off with using, as Andy said, Audrey House at Kingsway, refurbishing that to current standards, and that's got 10 beds within it. So we'd then move the enhanced care ward from Radbourne, which is a 10-bedded ward, to Audrey House. So that's 10 beds for 10 beds. We will then refurbish the enhanced care ward and a wing that's adjacent to it into an 18-bedded ward. And then we'd then close down Ward 35, which is currently 20 beds, and move that into the refurbished 18-bedded ward. So the only slight loss of beds we'll have at any time is about a 9-month period where we'll be 2 beds down. But the Decant Program is a rolling program.
Thank you. Councillor Hussain.
Thank you, Chair. I think this is a welcome opportunity for us to replace what we've currently got, including dormitory accommodation. But more impressive is our aim to provide acute care, where currently we are placing people outside our county. And that in some cases actually causing huge stress. I am aware of a case, I was approached by a father who's actually in his 80s himself, and his son was placed somewhere near Leeds in Yorkshire. He couldn't drive, and he was the only person, he's only got one son, and him and his wife had to travel frequently to Leeds to see their son. And I think as councillors, we have been arguing for quite some time that we should have facilities which are more local to people, because if someone's placed 80 miles, 100 miles away from their home, normal surroundings, it doesn't do their mental health any good, and actually probably adds to their stress levels. Once they lost contact, in some cases they would do, because not everybody's able to travel up. So that's a welcome opportunity for us to do that and establish those facilities locally in Derby. Can I just ask the question, in your report you've said you would like to see 14 beds, acute beds. Would that number be enough for us to not have to place anybody out of the county? And secondly, how many patients have we got currently which are placed out of the county? That will give us a bit of an idea whether 14 beds are going to be sufficient or whether we will still carry on placing some patients outside the county.
I'll take some of that, Councillor Hussain. Currently, we've got 16 patients who are outside the county in psychiatric intensive care units. Our acute bed out of county area is either nil or 1 or 2, depending. I can't tell you exactly at this point in time, but I can tell you we have 16 people in psychiatric intensive care unit. The fact that Derbyshire doesn't have a psychiatric intensive care unit has been problematic. What we're striving to do is to re-procure as local as possible quality psychiatric intensive care unit until we have our own provision built. And mindful of the kind of trauma you've described, we're going to see what we can do to put in a transport facility, should that be needed, whilst we have this interim period of still requiring local psychiatric intensive care unit. There are many challenges with the market and bed availability, so the sooner we can build our own and extricate ourselves from that, the better. But having your own psychiatric intensive care unit allows better flow of patients, allows the consultants to have better handle on the progress, and controls your length of stay. So the work we've done and the modelling we've all done together certainly suggests that 14 PQ beds alongside the enhanced care ward should be sufficient to meet our needs, in answer to your question.
Sorry,
Thank you. Did you want to come back? Do you want to come back on that, Councillor Hussain? Yeah.
Yeah, well, I can either wait or what I was wondering was, because in the interim period, people are still going to have that difficulty which I mentioned, and as you've suggested that you are able to offer some help and support, can we incorporate that in our recommendation that in the interim period where patients are placed out of the county, that the health providers are actually offering them help and support to their relatives, parents or brothers or whoever they are, to enable them to go and visit and bring them back.
It's not an obligation. It's not an obligation on the NHS to have to do that, but we recognise this may cause difficulties in the next couple of years, so we'll certainly look at that. Yes, we would welcome that as a recommendation.
Sorry, Councillor Hussain. Would you mind articulating that again, slowly for us, please, so we can agree it?
I was suggesting that we actually make a recommendation
Yeah.
that where patients are placed out of county, and they're some distance away from Derby, those people who are caring for them, their carers, should be offered assistance to visit their loved ones or the person that they're caring for if they have problems getting to the facility, wherever that might be.
Right. You think that's from the NHS, that assistance, do you think, or are you not specifying? Do you want to specify that that should be funding assisted by the NHS or just assistance?
The process should be facilitated. I'm not going to be prescriptive exactly how that's done. All I'm saying is that the carers ought to be enabled to meet the person that they're caring for. How it's exactly done, I'm not going to prescribe that they do it this way or that way.
Thank you very much, Councillor Hussain. So I think what I'll do is I'll come to the end of the questions, and then we'll look, and then we'll take that recommendation and see if everyone's in agreement with it. Thank you. Councillor Lonsdale, you wanted to ask a question.
Hello. Thank you for your report. It was very good. I have two questions, if that's all right. How are you going to be consulting with local residents? I'm thinking particularly of the Manor Kingsway residents who are very close to Kingsway Hospital, and I'm sure they will want to get involved in helping if they can. And I was interested that you said that Audrey House rehab wasn't being used very much, and I was wondering what the reason that the rehab wasn't being used to its full capacity. It's rehabilitation seems to be quite important to me in this area. So, yeah, yeah.
Okay. To answer your first question, yes, engagement of the local residents is will be part of the engagement plan over the summer months, particularly those residents that are on the side of the site where the new development will be. In terms of rehabilitation, there is an existing alternative rehabilitation unit on the Kingsway site, and at the moment the beds and the services that are provided there are sufficient for the rehab needs, which is why we have the opportunity to use Audrey House as an interim decant.
Thank you. Yeah. Any other questions? Comments? Okay. Thank you very much. I just have one, and in some respects you may have answered it anyway. And in the report you say that the funding you received was less than you'd initially hoped for. So, and that you'd had to reconfigure the services accordingly. So, can you give just some idea of what that has meant? Obviously, we know the money is welcome. I just wondered if you could elaborate a little bit how you've had to reconfigure them from what you had originally hoped for.
If more national money had been available, then having a new build that all on the Kingsway site for Derbyshire South we would have been able to not utilise have to refurbish the existing Radbourne unit to finalise the dormitory eradication. But having said that, the 80 million is a fantastic investment in Derbyshire, and so we are able, with the 54-bed new build on Kingsway, and then a refurbishment of the existing Radbourne unit to provide the single rooms and en-suite, so it's the same level of accommodation, to ensure that we don't lose any beds. So it really is just in terms of sites. And as I say, they're 4-minute car drive, a short walk between the sites. So.
Right, thank you very much. So any more questions? Okay, can I suggest then that we just make a note that we, if we are all, I'm asking you if you agree with this, if we say something like we welcome this opportunity for improved mental health care inpatient facilities in the city and county, particularly the previously absent psychiatric intensive care facilities. So we make that as a note in response. But and we would add Councillor Hussein's recommendation, and being that where patients are placed out of the county and or at a distance from Derby, their carers should have assistance to enable them to visit their loved ones. So is everybody in agreement with that? Yep. Yes. Okay, thank you very much. So if you could note that, please, Lindsay. And I'd like to say thank you very much for a really informative report. It does sound quite exciting and beneficial for all of us. And we do look forward to you coming back here to give us further updates. Thank you.
Thank you.
Right, so next on the agenda, we have an update report on London Road Wards 1 and 2 and cancer services from Gareth Henry from Derbyshire Healthcare NHS Trust.
Thank you, Chair. It's Gareth Harry, but that's fine.
Oh, okay. I do have Henry here.
Yeah,
but,
I know you
but
do.
I mean, you could take
I
you could take a Harry. We can get a Harry from a Henry, can't we?
It's close enough. Close enough, Chair. Thanks for having us tonight. Although I'm Gareth Harry. I work for Derbyshire Healthcare, one of their exec directors. But I am attending tonight on behalf of University Hospitals Derby and Burton and also the CCG, because this is a piece of work that we're doing on behalf of all three organisations. And you've obviously had the report in writing, so I'll try and summarise. Essentially, the requirement of University Hospitals Derby and Burton to, at pace, rapidly step back up their cancer and other planned care services within an ongoing COVID-secure environment has meant that they need more space than they are currently able to accommodate at the Royal Derby Hospital site. So about 4 weeks ago now, Derbyshire Healthcare received a formal request from UHDB for us to move our current ward for service for older people's mental health at London Road to be able to accommodate an expansion of their rheumatology outpatient services and their lymphedema clinic for them to operate those services on the London Road site. So in terms of patient safety and operational reasons, we agreed to that move because acknowledging the priority for the stepping up of cancer services. The CCG agreed to that move, and the wider Joined Up Care Derbyshire Planned Care System Board, which oversees cancer services across the whole of the city and the council, agreed as well. Now this is going to be a temporary move. We're not suggesting that this is permanent. We know that the move of this service to the Kingsway site has been discussed by this committee before. And we know that if we want to make this move permanent, we need to engage and consult with the public before we do so. But because of the urgent need to step up cancer services and within a COVID secure environment, we are making this decision temporarily to move the service should, at the point at which we wish to make this permanent, we will of course be going out to public engagement and consultation. The service that we're moving is an older people's mental health functional illness service, so it's people who are over 65 who are inpatients because of underlying functional mental ill health rather than dementia or delirium. The service will move to Kingsway. The date for the move is Wednesday the 16th, which is tomorrow. And it will place the service close to our other older people's mental health services on the Kingsway side, which do cater for people with dementia and delirium. Other than that, a brief summary, I hope, of what we're proposing and the contents of the paper. I'm happy to answer any questions or hear any comments that the committee wish to make.
Thank you very much, Mr. Harry. Are there any questions? None at all? Councillor Froggatt just beat you to it, Councillor Hussain. So.
It might not actually be relevant, but with the previous and then yours, nobody's actually mentioned children's mental health.
Okay.
So is there anything happening with that? Do you know?
A more general question about children's...
Sorry.
Well, no, it's fine. I'm happy to answer. There is an awful lot happening in terms of post-pandemic response. So we've received, on behalf of the whole of the mental health system across the country, received another £500 million as part of the spending review announcement by the Treasury in October, of which Derbyshire and Derbyshire is £5 million. So some of that, because it is non-recurrent in nature, one-off monies in nature, we are investing in terms of backlog clearance for children and young people services, so that the backlog of waiting times and the waiting list that's built up over the pandemic, we can start to address in the year ahead. So that's part of it. In terms of the longer-term funding that predated the pandemic as part of the long-term plan for mental health, we are investing this year and next year another £5 million into creating crisis and home treatment services for children and young people. That will be provided by Derbyshire Healthcare in the south of the county in the city, and by Chesterfield Royal Hospital as the CAMS providers in the north of the county. So there is not only investment to address some of the issues caused by the pandemic, but we have got other additional monies that are going into improving the offer for children and young people, and with the aim of avoiding admissions to Tier 4 beds, which is the inpatient CAMS service. And as with PICU, Derbyshire doesn't have a Tier 4 provision, so it does mean children and young people moving outside of the county when they need that service. So by having a crisis and home treatment service, we would be avoiding more admissions to Tier 4 beds. It is. It is. Thank you.
Thank you. Councillor Hussain.
Chair, I think we should recognise that there is a huge backlog of people waiting for some sort of medical intervention. And it is quite difficult to abide by the COVID rules and provide the services with the same efficiency and speed, etc. There's always going to be a question of whether we've got sufficient space to be able to do it. However, I don't mind current patients being moved from Ward 1 to allow other things to happen on that spot. But I would like to have some reassurance that it's not going to be at their expense, that their quality of life, quality of care is not going to suffer at all as a result of that move. And if you could give me that reassurance, I'll go along with what's being recommended.
Well, you'll have heard before when we were previously talking to, I don't know about the membership of the current committee compared to the previous membership under the council. So, but we have previously brought the permanent move of this service to the Kingsway site before the committee. And that is still our long-term ambition, but this is a temporary move that we'll come back to when we want to make it, when we wish to make it permanent and are able to do that. So we do feel and believe that the facilities that the service is moving into are superior to the ones that they're currently in within Ward 1. So it is a purpose-built mental health facility rather than an adapted ward at London Road. It's compliant with all regulations at London Road, but the Kingsway facility that we're moving it into is superior. We also think that the surroundings at Kingsway are superior to London Road. We also feel that the parking arrangements for visitors and carers, because they are free, is superior to London Road. So there are a number of reasons why, even on a temporary basis, we think this is a better experience for both patients and visitors and carers.
Thank you. Councillor Pegg?
Thank you. Just following up that, after the temporary move, what sort of time scale would you have for entering the consultation to make it permanent?
I think in the covering paper that you've had from the CCG, they're talking about, I don't know what word they use exactly, but I think it might be imminent or very soon or something like that. We've obviously got to plan a consultation properly. We'd want to come back and discuss our plans with you and get your views on our plans around it. But I think we're talking in terms of months, not years. So I would hope that we'll be able to deliver the consultation about a permanent move within this financial year.
So I know Councillor Councillor Froggatt wants to come in. Sorry, but just on that then. So as it is, you're not envisaging patients being moved back to London Road before the permanency of this site being...
No, because of the service, because of the nature of the work that UHDB need to carry out in that space.
Okay, thank you. Councillor Froggatt.
I'd just like to pick up on the free parking.
Okay.
Look, you're smiling already.
I'm interested in what you're going to say.
Well, yeah, it's free. It'll be free parking up to now, but once everything's established and up and running, will it revert to, like the City and the Royal, and the DRI?
I can't.
I know.
I can't envisage a time when we would seek to charge people to park at Kingsway.
Yeah.
It's never been. It's never been on the agenda.
Right.
Similarly to other community hospital type facilities around the county, it isn't something that we do.
Oh, good.
I wouldn't like to be the person coming back to overviewing scrutiny, proposing the imposition of car parking charges at the hospitals. I'm not planning to do it.
So just a follow-on from that then. Obviously, you've already got patients at Kingsway, but this is a change for certain carers and visitors to these kinds of patients. So I'm afraid I don't already know this because I've never had to visit Kingsway in this way. But what are the buses like to Kingsway?
The bus routes from the centre of the city out to the Royal Derby Hospital site are excellent, and I think it is probably the busiest bus route in the city. It is then a 10-minute walk from Uttoxeter Road round to the Kingsway site. There currently isn't a scheduled bus service to the Kingsway site provided by Arriva or Trent.
Councillor Frog.
So if I could I'd paused, but for a breath. As part of any permanent move, a travel analysis will be a key, and the impact of the changes to travel will be a key part of that proposed move, and would definitely be something that we want in the views of the public on. as part of that consultation. So we'd be conducting a travel analysis, but also we'd be wanting strongly to hear people's views on the impact of that on carers and other visitors.
Councillor Foggett?
It's just that, I mean, I'm councillor on Mackworth, and as you know, Mackworth it's like a 5-minute walk, but it won't be when the new road's up. Plus, there's still no crossing being done with Highways England. How they're going to sort that out, I don't know. And it's the same with Alistair. They'll have to go into town, and Darley and that, into town to come out of town, basically. It's like adding an hour onto a trip, isn't it, for a 15-minute walk?
Yeah, and I'm not aware of the bus routes in detail about how around the edge of the city, how, for example, from Mackworth, for example, to the Kingsway side. I think Derby, like most cities, relies on radial transport routes routes into the city and then back out. So even on London Road, it wasn't great for everybody, and probably if you were struggling for mobility, it did involve into the bus station and then back out for a bus towards the station or Alveston. But of course, for many people, London Road would be a walk from the bus station. So I think it's acknowledging that it isn't perfect as an interim solution, and some people will be impacted by the travel, but that would be something that we would, as part of any consultation about a permanent move, we would want to hear the views of people very strongly, very clearly, and it may well be that would be the point at which we look at other solutions for people. We have had conversations now with University Hospitals Derby and Burton about visitors and carers being able to use the shuttle bus between the London Road and the UHDB site. So we're confident that that's in place for the people that need it. We've consulted with every carer of a current patient, and we are therefore confident that no one has raised any issues around the current carer numbers for whom this is a problem. We'll keep that under consideration, and we'll also be looking to support people with additional transport costs for future carers who are going to be coming to the Kingsway site if it is if the transport issue is a problem.
I will come back on that slightly in a minute if you bear with me. But any other questions from anyone else right now? Okay, then just so on that, and bear with me. The shuttle bus, where does the shuttle bus currently go to and from? Did you say?
It goes from the London Road site to the main Royal Derby Hospital site.
Okay, so. Could that, I presume, couldn't the shuttle bus not do a slight detour sometimes? Because it's really not very far, is it, if you're in a bus?
Not far in terms of distance, but in terms of the time taken with the traffic lights and then getting back, I don't know. We could certainly explore the potential for it, but I can't make a promise to the committee tonight that we'd be able to deliver that.
Okay.
But what I can say is that where we've got carers and visitors for whom it is an additional inconvenience coming to the Kingsway site, that we were happy to support them with additional travel requirements.
Thank you very much. Any further questions? No? So are we all just happy just to note this report? Yeah, obviously it's, given that you're doing it tomorrow, it is quite late coming to the committee.
We would have loved to have come earlier, but with the making of the council, we weren't able to. And PERDA.
Sorry, I didn't hear you. With the
making of the new council and PERDA, this is the first opportunity we've had to discuss it with you.
Okay, that's fine. Yeah. Well, thank you very much for your report. It's very good, and we look forward to further updates in the future. Thanks very much. Right. The next item. Do we have the presenters? They're not here?
I don't think they are. I'll take us checking now.
Okay.
I want to adjourn it if you'd like to say something.
Okay, well, we'll just adjourn the meeting for a moment then while we wait for the next... So we return after our brief adjournment as we have the current speakers in the council chamber now. So we move on to the report on the London Road Community Hospital Transformation Project Wards 4, 5 and 6 from the report from Louise Swain from NHS Derby and Derbyshire CCG and Michael Hammond from the University Hospitals of Derby and Burton. Thank you very much.
Hello, good evening. So I'm Mike Hammond and I'm the Urgent Care Programme Lead for Derbyshire. And as introduced, my colleague is Louise Swain, the Assistant Director of Acute Commissioning. And we're here tonight to share with you the progress that we've made supporting our patients and citizens to receive the care they need in the best surroundings for them. So I don't intend to go through the presentation that we've sent through in advance of that. I just want to highlight a number of key points and explain the history of our project to date. Louise will then explain the next steps and then we'll both be happy to field any questions. And if there's anything that we can't answer, we'd happily take them away and bring them back to you in written form. So the first thing that we both wanted to say was this project, the work that we've been doing at London Road is part of a longer term commitment that we've had in place. So it's under the umbrella of Discharge to Assess, and that's been in place across Derbyshire for over 5 years. Alongside that, we've got the Home First model, which is a successful Derby City strategy, and that works in partnership with the NHS. And we're here tonight in the middle of quite a long journey, and we're not at the beginning, and we're not yet at the end, but we're at quite a significant moment, and we wanted to share that with you. So the national guidance around how we discharge patients from hospital is quite clear. So there's a best model of care that suggests or informs us that 60% of patients who we discharge from an acute hospital should be cared for at home and should have their assessment and treatment at home. 30% of those should be supported in local authority assessment beds with health support, and 10% of all patients, complex patients, in a community hospital which meets their needs. In Derby City, that community hospital was the 3 wards that we had in place at London Road Community Hospital, wards 4, 5 and 6. And in 2019, rather than 10% of patients seen at London Road in our community hospital setting, as was the target, we saw almost 40%. So we didn't have something quite right. So just taking a step back then, we've not been getting it right. So when we looked at the national guidance and we have clinical audits and we had independent consultants coming in to support us and take audits of our activity, they told us that in order to effectively assess our patients' long-term care needs, this is best done in their own home. And as I've said before, in 2019, the vast majority of patients were not being assessed in their own home. When we clinically reviewed the patients we had at London Road, that 40% of patients that we were discharging into those beds, we found that 80% of them didn't actually need a hospital bed, and yet we were discharging them into community hospital beds. So why was that? Well, it's because those beds were available as a starting point. They were a safe option. People and clinicians felt it was an easy option for us to transfer patients from a highly pressurised acute setting into a community hospital. Other hospitals that we might prefer to put a patient onto weren't available to us. And lastly, some of those alternatives that we had were expensive and we didn't necessarily have the staff. Then COVID hit us. And when COVID hit us, patient numbers in our hospitals and in our health system reduced dramatically. When we looked in the first couple of weeks of the COVID hit, the number of patients that we were discharging on complex patients reduced dramatically. And then during that first wave of COVID, there was some national guidance released jointly between ADAS and NHS around management of patients requiring discharge. And alongside that guidance came some additional funding, which allowed us to provide patients with the most appropriate setting, not their usual setting. So aligned with lower demand, aligned with increased funding from the centre to help us support health and social care discharges and changes in acuity, it allowed us to more effectively meet our patients' needs. And within 3 weeks, the 3 wards that we had at London Road Community Hospital were empty. So now, that left us in quite a fortunate position, if we take COVID off the table, in which we had an almost clean slate. So we had an opportunity to review our existing strategy and our plans in a way that we'd never been able to do because we weren't under the same operational and financial pressures that we'd always been historically. So, okay, what are we going to do? How do we make sure that we don't go back to the old model, which was a failing model, which was judged as inappropriate and not meeting those patients' needs? And how can we better bolster that home offer and that home first offer? So it was at that point that as a system, we decided to use the resources that we had in those 3 wards, not to reopen them, but to turbocharge the delivery of our strategy. So instead of reopening those wards, and putting our staff in there and paying for the cost of the care, we invested that money in the areas that we've always wanted to. And in the pack, it goes into some detail, but I'm just broadly going to highlight on the 3 most important areas. So number 1, we boosted home care, delirium and dementia support to a level that allowed more complex patients to be cared for and assessed in their own home and to develop an enhanced 24-hour service, something that we'd always been trying to do, but we'd never necessarily had the time or the scale or the resources to do it. Secondly, we developed a dementia palliative care team which allowed patients to be discharged to a supported care home with flexible trained staff rather than leaving an acute hospital and going into a community hospital. And thirdly, we developed a high-level specification for an independent city nursing home to deliver community-supported care. These changes that we've put in place, facilitated by COVID and taking on the circumstances of the position that we found ourselves in, are absolutely 100% aligned with our existing strategies. So if we look back at the existing strategy around Joined Up Care Derbyshire, around the Derby City Home First strategy, around the Derbyshire Community Health Services Foundation Trust strategy, and the University Hospitals, Derby and Burton's strategies, it's all in there. So, and each of those, when you put them together, had that aim of meeting the patient's needs more effectively, more efficiently, and with the aim of delivering better patient outcomes and higher patient satisfaction. So we're on the right track. We're doing the right thing. It's part of our long-term plan, so we made a decision. Let's do it then. Let's do all of that, and let's complement the existing services and the progress that we've made over the previous 5 years. Let's train our existing staff to a higher level. Let's recruit new staff. Let's give them a permanent contract and job security to allow greater retention. And let's allow hospital geriatricians to work with us. And just so I'm clear, the staff that I'm talking about here are local authority care workers. So we've invested the money from health into our local authority care workers and are training them now to a level through the Home First team to allow them to meet the patient's needs in a much more safe and progressive and positive environment. So where are we now? Well, it is early days. These things take time. We can't just recruit 50 people overnight, but we've made great progress. So the results so far are very promising. The proportion of patients that we now discharge home or to a social care assessment bed has increased from just over 50% of all discharges, as was the case pre-COVID, to nearly 80%. So we've made a significant step change. We're continuing to lead the process of the investment. We're continuing to support the progress that we've made so far, and we intend to continue to deliver and learn from where we've got to. So that's where I'm going to pause now and hand over to Louise.
Thank you. Thanks, Mike. Excuse me, I'm a bit croaky today. You've heard from Mike about the reasons for the changes, and I just want to kind of reiterate they are in line with the national discharge guidance that we have to follow. They are in line with our local Home First programme that has been so successful here in Derby City, and in line with the Discharge to Assess programme, which Mike has outlined. And it is an integrated health and social care provision and an integrated delivery model, which is generally enhancing what we have already and allowing us to have more of what we have already. So the slide deck in your pack does give you hopefully a flavour of the programme, perhaps in a bit more detail than Mike and I have got perhaps the time now to go into. But really it's about allowing patients to be discharged home, or more people to be discharged home, when ordinarily in the past they would have probably gone into a care home or into the wards 4, 5 and 6 at London Road. But that's not to say that we haven't got beds also available. So we have the Perth House beds available, and also the community hospital beds run by Derbyshire Community Health Services, that's available. So it's an integrated model. We've got a range of more enhanced provision, and the early days it does look like it's working better. More people are being discharged home, and in particular the change is allowing more people with more complex behavioural needs, usually caused by delirium, to be safely supported back at their own home instead of being admitted into a care home, which we would have ordinarily have done before. So it's enhancing the already robust provision we have. It's an integrated provision, and it's doing that by having calls available over a night period. So home care workers can actually go into people's homes during the night, and it's also supporting and training other carers to be able to support people with more challenging behaviours, and in particular supporting family members and carers themselves. It is endorsed, and the training is provided by Dr. Jane Yude from UHDB, who is a geriatrician, and the case study work that we have done so far, it is looking, as Mike says, very positive. So to give you an example, there was a frail elderly patient who had an ankle injury, was admitted into hospital, had an operation, was then discharged, but unfortunately had an infection, had delirium, was readmitted into the hospital, and the infection was a urinary infection, and it caused delirium. So what we were able to do was for her to be discharged back home with this intensive and enhanced support, of which she had 20 days of 4 calls a day. And then after the 20 days, that was reduced to 1 call of 30 minutes a day. And the patient, the family were really happy with the outcome, and the lady was able to remain at home. Okay, so that just gives you kind of a flavour of what we've been exploring. So, as Mike said, we've been in contact with our regulators, so that's NHSE and I, and they have said that we don't need to hold a full-scale gateway review, but we do need to make sure that we engage with the population, with our key stakeholders, and we're absolutely committed to doing that. So that's one of the reasons why we're here tonight, to try and help you to have a bit more information about the changes, and also to really give you the opportunity to ask any questions, and to help us to work out how we are going to engage over the next 3 to 4 months with our key stakeholders, HOSC being one, here in the city and the county, but also our staff at London Road that were working in London Road, staff in the integrated services, patients, people living in the community, their families and their carers, GPs of course, and also the Place Alliance in Derby City have offered a confirm and challenge in terms of during the process of developing the business case and engagement. We have been collecting patient experiences. We have carried out a number of audits to try and understand patient need. UHDB, so that's the Royal Derby Hospital, have been liaising with staff that have been redeployed, and we want to do more engagement. And so in a nutshell, that's where we're up to. And I think you've probably heard enough from Mike and I. So it's over back to you for any questions and comments.
Okay. Right, thank you very much for that. So I think Councillor Pegg had his hand up first of all. Thank you.
Thank you. I've got a couple of questions. Firstly, have the changes sped up discharges from hospital? And secondly, following the changes, in the report it said that wards 4, 5 and 6 were repurposed to help with the COVID crisis. Once, hopefully, the COVID crisis abates, what are the plans then for wards 4, 5 and 6 for further repurposing?
So, to answer your first question, it's a difficult question because there's so many different factors involved in discharging patients from an acute hospital. And the challenges that we're facing now are significantly different to pre-COVID times, and actually they're different to the COVID times when most people's family members were all at home and wanted their family members at home as well. So we recognise that the world moves quite quickly actually. The honest answer is that yes, it has. I think that we are now in a position to make more effective decisions and that we've got resources in the right place. There are so many things involved in a hospital discharge that you can be waiting for your medicine and that can cause a slight delay. The most important thing for us is that we discharge people as appropriate, we discharge them in a timely way, but we discharge them to the setting that best meets their patient's needs. And this work that we're doing at the moment is really fundamentally aimed at doing the latter. There are lots of other things that are in place, which if we had the time I could tell you, which is actually my day job, is around improving.
Sorry to interrupt there. I'd just like to say that actually we're relaxed about time. Actually, we're ahead of schedule. So
okay.
Please do feel free to. I know I did ask people to be succinct, but actually we've got time. So and I do appreciate the full detail of what you could tell us. Thank you very much.
No problem. So just to finish that point then, the most important thing for us is that patients' needs are met in the right place at the right time. And this is really helping us to do that. The actual number of patients what I didn't say in my presentation because we didn't have time is that out of everyone that's discharged from hospital, only a small proportion of them are identified as complex needs. So if I go in with I've rolled my ankle playing football, for example. This isn't for me, these pathways. 85% of people in hospital are just discharged home anyway, whether as an outpatient or as an inpatient. And for them, the discharge process still can be a bit lengthy and frustrating, but that's not this proportion. But actually, 85% of the hospital is the majority of the work there, and that's where we spend quite a lot of our time trying to speed up discharge processes by making sure that the drugs are in place, the clinical rounds are done in a timely way, we've got the right information and so on and so forth. This cohort of patient are that 15% of the population, which are mainly in the more elderly and complex, that really do need specific onwards care. And actually for that patient population, the timeliness of the discharge is less of a problem because we kind of know when they arrive what we're hoping to achieve in terms of their discharge. The problems that we have with their timeliness of their discharge is really around the accessibility of the appropriate care going forward. So have we got the right care? Are we able to deliver that care in home? Is there capacity at Perth House, for example? Do we have community hospitals and so on and so forth? And if we don't have that right case mix, then we have to make less good decisions. And previously those less good decisions were to move them to London Road Community Hospital, which they still received care, but as our clinical audits were saying, it was care that could be better delivered elsewhere. Your second question, which was around what do we do with the voided estates on London Road 4, 5 and 6, is a good one and is now becoming a much bigger question than just this particular project. So there's a specific programme of work that's in place that sits alongside the Mental Health Trust. I think you had a presentation before us about some of the wards and what we're trying to do there. Our primary care partners, our social care partners. At the London Road site, we've got a Derby Urgent Care Centre as well. So we're really now looking in the round about what would be the best use of those resources for that physical space in the heart of the city, and how could that meet the needs of our patient population and citizens, which aren't just limited to health, which is what we were using before. So that's a rather long way of saying we don't know yet, but it's certainly something that gives us an opportunity to work through, and that's exactly where we are at this moment in time.
Thank you very much. I think Councillor Foggett was next, and then...
Thank you for the presentation. Mike, you pointed out that when they leave the discharge lounge into home, that there was local authority care workers to go into the homes. Well, we haven't got any. Derby City Council don't have many. Most of them work out at Perth House and what have you. And even when we do have those because they come out the discharge lounge, Derby City Council pick it up, so a couple of workers go out, and normally it's about 2 weeks, and then it's handed over to the private sector, if that. Now, the private sector is not working. A lot of them are absolutely awful. I get lots of complaints, and I can assure you other members here do. What is, I know it's a daft question, but the people that are sent out, discharged, then they go into the private sector, how many actually return to the hospital through dehydration, delirium, because they're not getting that care? You know what I mean? They're not getting the proper care. People are missed, waiting for medication. Is there a regular turnover of them coming back?
So that's a really good question, and one of the things that we, in a more detail. So let me start at the beginning of that point. The recruitment problem, which is I think where you started. So I totally acknowledge that. Now, actually, the recruitment problem in Derby City is slightly easier than the recruitment problem in Derbyshire County, which isn't what you asked, but we're discharging patients all across Derbyshire and wider. Now, I alluded to it in my presentation, but I probably skipped across it quite quickly. So when we started this, we acknowledged it was going to be difficult. These are not the most highly paid jobs in the whole world. They're difficult, challenging, demanding, and you need a certain type of characteristic and skill set of people who want to do that. And at the same time, in certain cases, you can earn more money, sitting on the till at Lidl. However, as a community, we rely on these people. So we knew that we had a problem, and working with Kirsty McMillan and Julie Knight's team, we went through an ambitious recruitment program to get, I think, 60 additional care workers in place. Now, went through all the national adverts, the recruitment campaign. And because this has always been a trial, we're going to try this, that leads its own problems, which was around, we could only offer temporary contracts, fixed term contracts for 6 months while, does it work, does it not work? And I think in the first round of recruitment, Julie Knight only managed to recruit 3 or 4 additional care workers. Clearly something needed to change. So Julie brought a paper back through to our group, which we took through Join Up Care Derbyshire, to say, look, are we serious about this or not? Forget the trial business. Do we think this is the right thing to do? We've talked about it for 5 years. Is it the right thing to do or not? If it is, let's put our money where our mouth is. So we have done. So we've made this money available permanently to Derby City Council to recruit permanent staff, and the offer that we give those staff as we recruit them is an enhanced offer. So it's not just come and work for us and then we'll kick you into the community and you're on your own. It's a much more supported, enabled, integrated approach, working with DCHS nursing leads, our geriatricians to help the training. It's an ongoing investment in people. And, it's not a £50,000 a year post, but actually there's a career progression within there. Now, I probably could have predicted that you might have asked this question, but I think the last time I spoke to Julie or Kirsty within the last month, I think our recruitment is almost up to 50 out of the 60 that we needed to get this up and running. So we're 80% of the way there, and this has only been 3 or 4 months. So I now feel confident that if we sell it in the right way and if we propose it in the right way, we can attract the right people, and we can reward them in that way. So that's, I think that is very good news, and I think that is just a good illustration of how we want to use this money, which is health money. Yep. Forget all that. Forget the boundaries and the way that we always used to work. It's the right thing to do. We'll put it there. Now, your next question was one of which is probably way above my pay grade. I am aware of some of the challenges in the private sector. There's an awful lot of work that goes on in the clinical commissioning group in terms of the management and the regulation and the appropriateness of that care sector. What I would say is that what we're finding is that, and I'll come on to how we report that and the readmissions next, but what we're finding is, maybe not brain surgery, but what we're finding is the greater the investment in the care that we deliver to the patients in their own home, and the more robust that is, and the more that we're able to meet their needs in that setting, the greater their recovery and their rehabilitation and their ability to remain in their own home is. So the proportion of patients who are going from our new model into longer term care is lower than our old model into long-term care. Now, so you can now see why that fits with Derby City's ambitions around home first, because not only is it better for patients, but it's better for us in terms of how we spend our money and how families see that care. Your last point is one of, like, do we know what's happening to these patients? Well, we had a meeting earlier on today, didn't we, Louise, with one of my colleagues who's on the programme team with Julie Knight. I say Julie Knight's name. Do you know who Julie Knight is? Yeah, okay. She's one of the Derby City employees and leads on the Home First. In partnership with Andrew Muirhead, I don't know if you know that name, who's one of our BI analysts in public health here, and our geriatricians, we're designing a suite of outcome metrics for all our patients so we can monitor what happened to them pre-intervention and what's happened to them post-intervention. And in those suite of metrics, we have things like readmission rates, how many got, and how soon did you get readmitted, and when. Were your long-term goals met in your home or in the community setting, or did you then need to go on to a nursing home or further? So I think what I can say is that I think this is information that in a couple of months' time we'll be able to bring back and demonstrate a good news story. But we're just in the process of collecting it. Now, just while I was saying that, one thing else popped into my mind that you'd asked me a question and now it's gone. So if I've forgotten one thing, let me know.
No, I think that was about it. I'm looking forward to the outcome.
Yeah.
And you're bringing it back just to see
Yeah.
what difference you're making. Because as we know, when it left, the local authority care went into private care, it went.
Yeah.
Yeah.
Yeah, can I just come in there? I will let you come in a minute, Councillor Hussain. I just want a clarification on that particular answer to that question because, to be honest, it was unclear. Basically, in the presentation you said you were going to train local authority care workers to deliver some of this care. And then you're saying you're investing, of course, as Councillor Foggett said, the local authority, as far as we know, doesn't directly, well, I was told last week, doesn't actually employ directly any care workers. They do it via the private companies. And now you're saying you've recruited 50 out of 60 staff that you need. Which are these staff and who are they employed for?
Yeah, to make a distinction, I think, in terms of the different types of care workers from the different sectors, I think would help in the clarification. So the enhanced, what we call Pathway 1 provision, which is to assess people, to rehabilitate people when they've been discharged from hospital, is provided by local authority staff. But in terms of the longer term home care packages, that is in the city area, is provided by private sector. So that's the distinction. There is a distinction. So that there are some care home workers that are employed by the City Council, but they are part of what's called the Home First Pathway 1 provision.
And have you recruited those 50 to work in that area then,
in that area,
and you train
yeah.
that area. So
Yeah.
when you are training up the local or the other, so when you referred to training up local authority care workers, were you referring to people just in that pathway, or were you referring to the care workers who are employed by private companies?
So we are initially providing that training for the Pathway 1 care workers, but the intention is to widen that training so that it does include private sector care workers as well, because obviously we've got to try and cover both. But I would say it's probably not quite there yet in terms of the private sector workers, but in terms of the Pathway 1, that's
Right, thank you. As we're still on the same question, if you don't mind, Councillor Sane, I'm going to let Councillor Froggatt come back in on this particular point, because I think this is very important.
As you said, through pathway 1, then you're going to move it, try and get the private sector into it. Will that be at a cost from the private sector, or will you be funding it? Because we know that if the private sector have to put money out, it will not happen. So, or meet them halfway on training, or, you do the training, but we know the private sector companies will not go into their profits.
Yeah, I think that's a very valid point, and I think, to be absolutely honest, our intention is to try and include them to be trained without cost, but I can't guarantee that we're going to be able to do that. But you're absolutely right. You're absolutely right. Yeah.
Sorry. So just to be clear then, so I know you're not there yet, but you are going to train the private care workers, and will they be then moving into doing Pathway 1 work, or you're going to train them and they'll still be in the other work?
So the intention is that the Pathway 1 home care workers will be linked to will be employed by the City Council. That's the intention. And Mike, I don't know whether you've got...
So we do have a net shift then of funding and services going from within an NHS service out into paying private companies to do the work?
No. So
sorry, I didn't make myself clear.
the specific. So in the care pathway, and what I don't think we fully, I fully got across in my presentation was, this isn't just about discharge. This also enables us to deliver care to avoid people going into hospital in the first place. But within what we call discharge to assess, which also includes admission avoidance, there's a very specific assessment period. And that assessment period, support, reablement, rehabilitation, is the period that we're talking about, not their care forever. So let's just take a really simple example of a discharge rather than admission avoidance. But a patient comes in, is a complex patient with health needs, social care needs, and has a delirium. In the old world, 9 times out of 10 we discharge that patient into a community hospital. And we did that because that was the easiest and safest pathway for that patient to be in. But that was all part of the NHS social care pathway commitment. Now, the most important thing for us is that these pathways, pathway 1, 2, and the 3 pathways that we're talking about, are an assessment period. We don't want to make a decision about a patient's long-term care when they're in a hospital, because we'll get that wrong, because they look very poorly, they are very poorly. We don't want to make it in a community hospital, because we're finding that we get that wrong. We're better making it in the patient's own home. And to do that, we need to wrap our care around the patient in there to allow them to stabilise, to rehabilitate, and to make a more effective assessment of their patient's needs. Now, that assessment period, this is the bit that we're talking about, we put the investment in, is the bit that's owned between ADAS and NHSE and I. So that's the bit that we're talking about investing in. It's a joint piece of work across health and social care that allows health and social care to come together to make the best assessment of what that patient's long-term care needs are once that assessment and stabilised period is over. Now, you made the good point that in Derby City, that assessment period has been driven down, which is good, because actually there's more intensive reablement and rehabilitation and better decision making earlier in that patient pathway to enable us to make a better assessment decision about what that patient's needs are earlier rather than it lasting months and months and months. That's good for lots of different reasons, not least it's more effective and efficient and allows us to see more patients, but also because it gives patients and their families more certainty about what their next care needs are. That's the bit that we're talking about today, and that's the bit that we've put the investment into, and that's the care workers that we're recruiting to and the money's going towards. It's that portion of care. Now, what happens after that when that assessment decision has been made jointly could be anything. It could be you don't need anything, you carry on living at home.
So can you just summary, please? Sorry, can you give a quick summary of this, please? Because I've got other questions, and I know I must bring in Councillor Hussain.
Yeah.
Thanks.
Sorry, so broadly, I do tend to natter on a bit. So broadly, is a very discrete section of the patient pathway. It's health and social care together. It's the assessment period. Long-term care is not within the scope of this, but we know that some patients do need it, some patients don't. That is a slightly different piece of work that is clearly linked to this and enables it, but isn't this piece of work.
Councillor Froggatt, you're happy. I'm still either non-comprehending or a little bit sceptical about what it is exactly you're training the private care workers to do, and actually the employment, just because we know that they have a large turnover of staff, unfortunately, and there are lots of reasons for that, which we can't solve overnight. And so I am concerned about relying on those kinds of staff to do certain kinds of work. So maybe you might want to come back. I do feel I've got to bring, I'm so at the moment I feel a bit sceptical or unconvinced, but I know you will want to come back to me. But I think I'm going to let Councillor Hussain come in first, because he may be able to offer an illuminating question anyway, I'm sure. Thank you.
I haven't got an illuminating question to ask, but I'd like to make one or two comments. I did manage a hospital discharge team from the DRI from 91, 92 until 2002. And we did have a discharge team which was dedicated to providing discharges with help and support from people who are trained in health matters, and also we used to call them home care aides. Mm-hmm. And they were more or less doing what you're suggesting that you're going to do, actually. That's what they were doing 20 years ago, 30 years ago. That's what they were there for. But things often change and people think something else will work better. And eventually I think they were dismantled and they were incorporated in something else. But that was the exact idea behind them, having them in the first place. Now, obviously, everyone wishes to discharge patients home where it's possible. Mm-hmm. But in reality, what happens is, you have somebody in their 80s, they go in a hospital with a stroke or something, or they've had a serious fall, or they've had a heart attack, which has incapacitated them. They've had the medical intervention. Once the medics are finished, you're looking at, well, what is the best option for them from here? So the the occupational therapist, the physiotherapist, and the home care staff, they get together and say, well, what is it that this person needs? In most cases, as you say, home care is sufficient. They provide home care 2 or 3 times a day, sometimes more, sometimes double ups. In other cases, they're saying, well, we can't be certain at this stage in terms of what their ongoing needs are going to be, so we would actually assess them somewhere else. They can't go home because they're either not weight-bearing, or they can't manage any risks themselves because they're too confused. So you're either looking at 24-hour supervision, which is not cost-effective, or you are looking at a very heavy cost of a care package if you are going to support them in their own home. So financially, often is not viable to have somebody in their care home. Because look, sorry, this is going to go on a little bit. You'll have to allow me a bit of time, because it is something that I've worked in for a long time. Personally, there's hardly anybody who can't be cared for in their own homes. It's a question of whether financially it's viable to provide them care, because it is possible to provide them 24-hour care in their home. Can local authority bear that cost? Obviously not. They will say, well, once a person gets in that sort of situation, we will fund a placement for them in a care home of some sort, either nursing or residential. In theory, I've got no problem with what you're suggesting, because people do want to go home. Vast majority of them do. Some don't. Sometimes the daughters and sons will say, we've been providing this much support, we can't do it anymore, and the person themselves will give up. And they say, well, I've had enough of all this. But in many cases, it might be possible. The financial cost is one thing, the cost of doing it. And secondly, I think my colleagues were quite rightly concerned that once you've had your discharge team, I'll call them discharge team, whatever you're calling them, once they've finished their input, then the package of care will be passed over to local authority for providing ongoing care. So if the person is going to live for another 2 or 3 years, that burden, financial burden, will be passed over to local authority. Now, whereas in a rehabilitation environment, the care is funded by health. There's no cost to the service user, or a small cost if they're in a resi home. But care at home is financially assessed. And if they have got the money, they pay the full cost. That becomes, sometimes, that cost is quite prohibitive. And then people say, so in principle, there's nothing wrong with what you're trying to do. But I think practically, I think more thought needs to be given as to, one, you've done your input, once you've completed your input for 2 or 3 months, they've stabilized, you know this is going to be the ongoing need from here onwards for at least next few months, then that cost will be expected to be met by the local authority. So that will add more financial pressure on local authority, that you'll be passing over a healthcare need into social care needs for which we currently don't have responsibility. So, I mean, I know you've been working with Kirsty and she must have weighed it all up. But there are certain aspects that I would like to take a look at more closely in terms of how this whole thing is going to work.
Thanks for that question. So, I think there's a couple of things in there. One, there is no passing of responsibility. A patient's needs are a patient's needs. And if a patient's got social needs, as decided by the system, a patient's got social care needs, and they need to be met by the local authority. If a patient's got health and social care needs, they need to be met jointly, and if they've got health needs, they need to be met by the health sector, of course. So long-term care is something that we can't solve, and it's not in this project. What we're talking about here is the assessment period post-discharge, or to avoid a discharge, that allows us to make the most effective decision about what a person's care needs are. That's going to happen regardless of whether we do this or not, regardless of which discharge pathway they go down. That's going to happen. There's going to be an end point where a patient, a citizen, one of our community members, has got a set care need. How that care need is then met and delivered and paid for is actually quite a few steps beyond the section that we're in. That is, if it's very complex, that would go through a continuing healthcare panel. If they've got very, very complex needs, which is health and social care coming together to allocate funding proportions to pay for that. But for normal, if you've got care home needs, resi home care home needs, the family meets that needs, don't they? Unless depending on the criteria that they've got. And none of that has changed, and this won't change any of that. So I don't think that the concerns that you've raised there, this will have any impact on that. And I'm not saying they're not real concerns, because they absolutely are. You know, the long-term funding of social care in the community, nursing homes, resi homes, however that is a big problem for this country and for our patient population. But what we're doing here has no impact on that, if I can put it that way, because it's for a very short period of their care while we undertake that assessment jointly between health and social care. And we trust that those assessments, which are made jointly between health and social care, are going to be made in the right way. And then the funding for whatever happens after that is part of the national guidance and template for how that should be funded. So regardless of whether they were discharged into a community hospital or at home, it would have no impact on that. So I don't think there's any additional burden onto any one provider, because it doesn't make any difference. What we're talking about is making sure that we get the right care to the right patient in that immediate pre or post hospital phase, so that we can make the right decision. And what the clinical evidence tells us is that you're more likely to make better, more effective, more efficient decisions if that happens in a patient's home, if that's suitable. And we found that in order to make that happen, we've needed to invest in those services to enable that to happen.
I'm going to thank you. Do you want to come back on that, Councillor Hussain?
Very briefly, but I don't want to get into kind of an argument or prolonged disagreement over this. But in all honesty, I mean, I know you'll probably be putting greater emphasis on some of these things. But in theory, the discharge arrangements which are currently in place should always do that, because the government guidance is, where possible, the first priority is to get people back in their own homes. So if that's not being done and you've identified certain things where it could be tightened up, that's fair enough. But it's not radical stuff, you know, it's not something that nobody's thought about. The emphasis always has been the first option. The discharge team looks at the physiotherapist, occupational therapist, and the care discharger. Is it possible to get this person home? If the answer is yes, what sort of package will they require? Is that package reasonable in terms of funding? If it is, they go ahead and do it. But you may be dressing it up differently, that it is something which is novel and new and is going to revolutionize the way we care for people. But the whole concept has been there for good at least 30 years, that the first priority always has been to get the person home, if it's possible and financially viable.
So I completely 100% agree with you. And this isn't a revolution, this isn't anything radical, this is just us trying to do it better. So as I said at the beginning, this has always been our plan, it's always been our strategy. It's not new, it was there 30 years ago. What is new is that patients with those complex needs are difficult to look after in their own home without support for families and for those patients. And previously, we were putting them in community hospitals, we were putting them at London Road, and now we don't want to do that anymore. So that bit is new. The principle is not new. You're absolutely right. The principle is exactly the same.
Thank you. I think you answered that one. I do have a couple more questions. I'm sorry, I know we're running over time, Lindy, but I think we've probably still got enough time. But I would like to bring Councillor Froggatt in very briefly again, and then I have a couple of questions as well. And Councillor Lonsdale also wants to come in. Councillor Froggatt?
I'd just like to say I do applaud what you're trying to do. It's a long time coming for the help with the elderly and the acute, with the health. But what Councillor Hussain is basically trying to take on is central government. So, I do applaud what you're trying to do, and I hope that it does happen and we get a better understanding of the needs of the people when they are discharged. Because we all know if you're at home, there is more chance of you getting better than anything else, because you have your family, or and you have visitors and all that. So yes, I applaud, and I really do hope you get this off the ground. And I'm looking forward to your next report.
Thank you, Councillor Froggatt. Councillor Lonsdale, you wanted to ask a question.
Thank you, Chair. Well, my question actually is around sort of transitions and the way you're communicating between agencies. So obviously you've got a lot of agencies having to work with these different these patients. How are you making sure they're getting consistent communication about say what the physio is saying, so that the person who's giving the medication knows that what the physio is saying? Have you got new methods in, or are you just trying to make do with the old methods?
Really good question. So one of the things that we've done post-COVID is change the way that we try and discharge people. Now, acknowledging that we're not reinventing the wheel, and these principles have been with us for years, it doesn't mean that we can't improve what the position is at the moment. Now, probably the biggest thing that we've changed is so thinking about the way that we used to the way that we used to discharge people. If they were in an acute hospital, if they were at Derby Hospital, you're under the care of the medics, and when it's time to be discharged, the medics then call in the OTs, the therapists, the pharmacists, and we make a multidisciplinary decision about what the next steps for that care package is. Now, that is a very acute or hospital-centric view of the world. Yep, it's through the lens of being a medic or in a hospital at that period in time. So what we've been working over the past few years, and we've accelerated post-COVID, is making that a truly multidisciplinary decision, multi-agency decision. So within the discharge assessment unit at Derby Hospital, we have social care teams from Derby City and Derbyshire County. So one of Julie Knight's teams permanently works there alongside our discharge facilitators, alongside our OTs, our therapists, and our pharmacists and our medics. And actually what we do is, rather than it being a hospital decision in conjunction with the family, it's then a multi-agency decision. So if a patient's going to be discharged onto one of our discharge to assess pathways, our complex pathways, inevitably they're going to get a mix of health and social care. And it might be 100% social care, like you don't have any health needs, but you need a lot of social care support. It might be 100% health needs, or more likely it's a mix of the two. But in order to make that decision, we found that by putting the right people in the right place to support that, they do it together. And then they're working on the same principles, the same pathway planning tools, and they're looking at the patient and seeing what their patient needs are and making that decision together. And that enables us, we feel, to make a better decision than if we were previously just making a decision as a hospital. So that's really important. And then I'm sorry to sort of go back to that and re-emphasise it, but
I think if you've already said the point, that's fine, thanks, because we are running out of time. I think you have answered that question, thank you. So I have a question, is how many beds are we losing or have been lost?
So, without sounding like a politician, we're not losing, we're gaining alternatives.
So hang on, I've got a question, and I do want you to try and focus on answering the question on this one,
that's
please.
Fine. So the number of beds that we had in our 3 wards at London Road totaled 76, Louise. So those 76 beds are now not open, and our patients.
So we've lost 76 beds then.
We've changed the resources from those 76 beds into the community.
You've lost 76 beds. You're not using them. There are those beds are not there anymore.
Yeah, they weren't needed anymore.
Okay,
yeah.
Right. So we've lost 76 beds. Okay, thanks. So do we know, you don't know what those wards are going to be used for at the moment. I appreciate this may not be entirely and why wouldn't those beds be repurposed, maintained and repurposed for other potential purposes?
They may very well be, but that's the conversation that's going on at the moment. What's the best use of that estate?
So at the moment you have no permanent loss of those beds?
Nope.
They could potentially. And what number, so do you not need, sorry, bear with me everybody, but I do think this, for me this is extremely important. I know we're running over time. So how many beds, so what about those people who absolutely do need to have some hospital care? How many beds do you have for those people?
So we've got provision through Derbyshire Community Healthcare Services. I don't know how many beds we've got, Louise, but a number of hundred. We've got our...
How many, sorry?
Louise is just...
All right,
Yeah.
okay, sorry, carry on.
Do you want me to? I think it's a total of 96 beds across the county that we have available that are community hospital beds.
So how many in Derby, though?
So there are no community hospitals.
So you've got none in Derby?
Derby, no.
Okay, so that means that, so what happens to those people who have no family to help or who have a very inadequate home?
So we do have what's called Pathway 2A beds, which are residential beds, but they're not nursing provision beds, which is Perth House, but it does have medical input into those beds. So it's not quite a community hospital bed, but it is a bed, and it is a 24-hour care for bed. So it's a slightly different to the community hospital bed, but it is a bed in Derby City, which is Perth House.
Okay, thank you.
And Louise, we also have the residential nursing home beds with health, 24-hour health support and social care in reach as well.
Okay, thank you. Right, I'm aware that we need to wrap up now. I'm sorry. I have given that a lot of time, but I think it's important. Does anybody else have any burning last point to make? So I have a series of, a little bit of a commentary here and possibly a recommendation, but I'd like the councillors' views on this. Something like this we could respond with. The board appreciates that for many patients with dementia or delirium, being in a homely and or family setting is beneficial. However, the board is concerned that many people do not have had adequate home provision to return to. That resources for home care resources may be stretched to the limit or may be inadequate. And we note that the number of hospital beds per head of population is already at a bare minimum. So therefore, the board would recommend that we did have, sorry, this is in parenthesis, we had some anecdotal evidence rather than statistical and rigorous evidence of the benefit of this care. So the board would recommend that further evidence of the adequacy of the post-transformation care be provided, especially relating to those who do not have any home family support, and that all the outcomes locally are reviewed prior to any permanent closure of hospital wards. Sorry, that is a lot to take in. I know for you to look at it. Well, do we accept that, or are there bits you want to change, or? Thank you, Councillor Fogg. Do you want me to repeat it really quickly? I know Lindsay is getting annoyed with me because we're running over time, but do you want me to repeat it? Councillor Lonsdale, Councillor Pegg, are you happy to support it, Councillor Pegg? It's broadly, it's a supportive comment, but it's sceptical. Councillor Pegg.
Could it be praised? It's rather long-winded.
Could we what, sorry?
Could it be praised? It's rather long-winded.
Sorry, I'm not clear what you want me to do.
Shorten it.
Not easily. As Churchill said, it takes a long time to write a short speech, so I can't sort of shorten it right now. Councillor Fogg, okay.
What is the are you going back to our next meeting, or will it be, well, you have 4 meetings a year?
Yeah.
And I'd like to keep on top of it. When would you be ready with some more input?
We're entirely in your hands. So this is our engagement and stakeholder management, and you are important people in this process for us. So, you know, broadly, I think if you meet quarterly, am I right? So if we could bring the information that was outlined there, maybe we'll firm up the words back to your next meeting in, is it September, October?
Okay, we could, thank you very much and offering to come back. So what we could do, Councillor Pegg, is we could, I gave Mordy, I wanted to put something positive rather than just the recommendations, but what we could do is just strip it down to the recommendations, which is that the board would like to see further evidence of the adequacy of the service, post-transformation services be provided, especially relating to those who have no family support. We also recommend that all the outcomes locally are reviewed prior to any permanent closure of hospital wards and the loss of those beds.
Can I just say, you stipulating on sites with no family, etc. It also includes the pathway one.
So do you want me to take that out, Diane?
Well, I'd like to make it more inclusive of everybody, not just...
Okay, well, I'll just take that out. So we've just got further evidence of the adequacy of the service post-transformation be provided, which I think you know what we mean by that, don't you? I don't think you've heard the discussion. You don't need us to elaborate it. And then that all the outcomes locally are reviewed prior to any permanent closure of wards and loss of beds. Are we happy with that? Councillor Hussain, is that okay? Thank you.
If we've asked for a report back in September meeting or October meeting, we can have further discussion on it before you take a major decision whether you could afford to lose a few hospital beds as a result of. Because we're not in that territory at the moment. All we're looking at is you've taken on board an initiative which you think is likely to work well. We'll go along with that, but we want information back to make sure that it is working as intended.
So thanks.
Any consequences.
Yeah. So we'll leave those recommendations for now then. Thank you. We thank you, but we will come back to, so we'll have those recommendations, but we also know that you're going to come back and talk to us in October. I think I need to wrap it up. Is it very urgent?
It's just a clarification. When you say local outcomes are reviewed, I'm sorry, what do you actually mean by that?
Well, what I mean is that you talk about, you give, I have to be very quick. In the report, you say that national evidence says that it has these benefits, but I don't think we've had an awful lot of detail on what the local outcome, the evidence locally is. Thank you.
Thank you.
Okay, right. Well, thank you very much for your time. We have given it a lot of time because it is really important. We are now running over time, but we do appreciate that. And if I could just make one quick point, and I think Councillor John Lonsdale supports me on this. I know you spoke very well, both of you, in the oral report, but in the written report next time, could we please have fewer initialisms and also fewer numerical reference with no reference back? I mean, at one point, for example, you said access with D2A referral to IDHH/H22 team. I mean, that is absolutely in speak and renders the report fairly meaningless. I mean, please give it, what you could do is just provide a glossary, but you've also got P3/2/1 with no reference back into the report from where that appears as what that means. So if you wouldn't mind putting some consideration to that when you submit a report next time. Thank you very much. Thank you. Right, sorry, now we do have to rapidly move on to the next report, Lindsay. Yeah. Yeah, okay. Do you like to adjourn them while they leave? We're going to restart the meeting after our brief adjournment, I'd like to apologise to Robin Dewis and Kirsty McMillan for keeping them waiting. We just had to spend quite a lot of time on the previous report. So following the fact that we haven't been able to generate the topic review as planned by the board last year, Robin Dewis and Kirsty McMillan have very kindly agreed to come to us and present a report, a brief report, another further update on learning from COVID. Thank you.
Thank you. So I know that we've met, and I know that we've met but not met. But I'm Robin Dewis, and the Director of Public Health. Hi. Last time when we had the meeting, I had an action from that meeting to particularly consider the beginning part of the pandemic and how prepared we generally were, and just to put some reflection onto that. So it's very much a narrative reflection on that I'm going to start with, and then we'll move on. So thinking about the early pandemic and the national and the local planning, then reflecting on our local response here. I've got a little bit for you around the progression of the pandemic and also thinking about the population impact, and then that leads on to some areas that you might want to consider for future topics or to consider further. So it was only last year, it feels such a long time ago, but just a quick run through of exactly how this all started in the early days. So the first cluster of cases in Wuhan were the 31st of December 2019, and it was only 2 weeks then until the first case outside of China, which was in Thailand. First case in the UK was the 23rd of January, and if you remember in those early days of those first cases, and that was a young person and their mother from China, they were very much contained, and there was a very large response to those individual cases. On the 30th of January, WHO declared a public health emergency of international concern. And I'll come on to that onto the next slide, because that's a little bit of our reflection around our response too. And our first confirmed case in Derby was on the 6th of March, and that was a hospital inpatient. And at that point, the information regarding that case was held by Public Health England, and they contacted us to inform us of that case, but we knew no more. We knew that there was a case, but that was the extent of the detail from that. So it was actually the 11th of March that WHO declared a pandemic, and that was the first pandemic that affected us and had been declared since 2009, since the Swine Flu Pandemic, which is also relevant, I think, in the later conversation. And in mid-March, the number of cases in the UK became such that Public Health England were struggling with the contact tracing. And what had happened with the previous swine flu pandemic is they got to this point, they'd done great in-depth contact tracing, they got to this point, and then they pulled back from that. And the pandemic spread within the population, and there was a different response at that point to it. So this is quite a pinch point, I think, at that. But it rapidly became clear from the national data, as you'll remember, that wasn't going to be an appropriate response, and our first lockdown was implemented on the 26th of March. So you can see there, over a 3-month period, initially quite a slow realisation, and then quite a rapid response. So just to reflect a little bit on that, previous pandemics, we were prepared nationally and locally for an influenza pandemic, and that was an entirely rational response. As you'll remember, the 1918 flu pandemic was the thing on everybody's mind, the swine flu pandemic 2009. That's what we were anticipating a pandemic was going to be. It was going to be an influenza, and probably from an avian or other animal source. So we had our own pandemic influenza plans locally and nationally, and this was led through the Local Health Resilience Partnership, part of the emergency planning, and this was a national process as well.
And if we look back at the other public health emergencies of international concern, which was that previous definition from WHO, we had Ebola, we had Zika, and we had SARS. And if we just reflect on those, WHO declaring a public health emergency of international concern in those circumstances didn't really have an impact on us. It was an international issue, but it wasn't necessarily going to impact on us in this country. And I think that's important, those two different aspects. Our previous experience of pandemic was influenza, and the previous emergencies of international concern didn't actually wash up on our shores. And I think if you reflect as well on the response in the Far East from the previous SARS outbreak, and we look at how they responded in the Far East, they'd had a very different experience. So if we think back to the swine flu pandemic in 2009, it was very much an NHS, and it was at the time was a Health Protection Agency response. This was a response to treat and to vaccinate individuals. So initially there was some antiviral medication that was given out to people who were positive, and then very rapidly it was declared a pandemic in April. By the September, October, there was a vaccination and a very rapid program of vaccination. And so a very different response that we would have to an influenza pandemic than we could have to a novel virus that we were even unsure how to treat at that moment in time. So locally, as I mentioned at that very beginning, we weren't given the information about the individual cases. All we could see was a number that was allocated to the city. So we knew each time there was a new case diagnosed in the city. And so what we did was worked with UHDB, with a local hospital, to look at their data, and they very kindly worked with us with their data to look at who the cases were, to give us that information around who's most vulnerable, who's most at risk, and to help us to understand what we needed to do with the population. And that was an incredibly challenging time, but was related to the fact that the process was all being nationally led. The data was held nationally. The contact tracing, as you remember, was established in the national test and trace process. And there was also the national guidance around that. And what we did locally was look at that data that we had, look at the guidance that we did have, and interpret that locally so that we could assist services both internally within the council, but also other partners around the interpretation of that guidance. And part of that was quite a significant amount of media engagement as well, radio, television, and also with the Derby Telegraph as well. So over time, as you'll remember, we had that increased data sharing. Around the summer last year, we began to receive detailed information about the cases, and that has rapidly progressed. So we've moved from knowing very little about the cases that we had to knowing the individual details of those individuals, but also being able to develop our local contact tracing team, where we can have conversations with each of those individuals to identify the contacts, and then now from this week also following up with those contacts. So it's a huge shift in where we've come from. And what I would say is that we were never set up to do that. It was never anticipated that this was going to be needed. When the Public Health England was developed from the Health Protection Agency, all of those health protection functions, the contact tracing, the identifying of infectious disease and following up with clusters and outbreaks, was all held by the Health Protection Agency and Public Health England. And so we've moved very much to a point where we're now looking at what is our role in the future in that. And I think it's a real learning point for everybody that worked very well at that time, but actually with increasing numbers of infectious disease, but also the local learning and that local contacts and what we can do through our other services was really key in engaging everybody with that process. What we've also had is a local incident management team, which has allowed us to include all of our partners locally, which has included the police, the infection control team from the hospital that works with the care homes, our appropriate directors within the council as well, so with Kirsty from social care and with education, so that we're all within that team and we can all share that information. And a really key really key input from our environmental health colleagues as well, who've been absolutely key in this response. So that has been really helpful for us to develop those relationships, but also to get a really clear view of what's happening in the city. And I think also that's a really key learning for me, in that establishing that has helped us so much in managing any situations that have developed. And from that, we've also got our groups that meet if there's any issues or particular issues to discuss with care homes, with schools and with the university. So we've got relationships and structures set up there that we can call to meetings very rapidly if there's anything that we need to manage. Now, we had very early on in the pandemic, we had an outbreak response plan that was developed in which these things are described, but it was only really when we implemented them that we could actually understand how best to make them work. I think when it's in a policy or a document, it's quite difficult, isn't it? It's the live experience, I think, that we've really learned from. And I think from all of that, there's a huge amount that we can take forward in the future. There's a huge amount of learning about practically the importance of those relationships and how we can manage such situations in the future. I just wanted to share this with you as a little reflection. Since the beginning of the pandemic, we've been tracking numbers within various local authorities, including locally, including in the West Midlands, which early on we very much reflected the case rates in the West Midlands rather than the East Midlands. And this is our SIP for neighbours. So these are our similar local authorities which have populations that would have similar characteristics to ours. And I wanted to show this to you because I think it demonstrates there's a lot of about the risk and the prevalence of the virus that relates to the population, but there's also a lot about chance and a lot about geography, because what we can see here, Derby is the blue line on there, Walsall is the red line, and actually as you can see, we track with Walsall pretty closely until the early spring, where Walsall has moved above us, and that was certainly the evidence early on in the pandemic. But you'll also see Bolton there as the green line, and you can see the evidence of Bolton at the end towards there, as the Delta variant has started to spread in Bolton, the impact of that taking off differently to other areas. And also the orange line, which is Medway, who were very impacted by the Kent or the Alpha variant. They were tracking quite low. The Alpha variant hit them and they took off very much to the top of the pack, as you can see, in a very different way. So it's just really a reflection that, yes, it's about our population, which is similar between all of these areas, but there's also that geography and that chance around the contacts and where the variants are and where they're actually entering in to the UK. So I just wanted a little reflection on the deaths as well. So from the data from last year, 2020, we had 2,750 registered deaths in the city. Now, 400 of them were confirmed with COVID as the cause of death, but only 16 of them had COVID as the only cause on the death certificate. So this comes from our information that we get with all of the contributory causes on the death certificate. So we can see what else is contributing. And we know that the deaths have been strongly linked not only to those other conditions, but also to health inequalities, to deprivation, to ethnicity, and to the social circumstances, so crowded housing, occupations of individuals. And I'm sure Lindsay will be able to circulate this later, so you'll be able to see it more clearly. But this is designed to demonstrate what the relative contribution of the primary causes of death in 2020. So the top blue box there is COVID, which you can see is very significant. The bottom orange box is pneumonia. Early on in the pandemic, community cases weren't being tested, it was only admissions to hospital. So if somebody died from a pneumonia-like illness in the community, we wouldn't necessarily know. If it was related to COVID, there may be some COVID cases within that. We can see that actually COVID is actually a small part of the deaths within that year, but a really significant one. And I had a look back at the previous considerations we gave, particularly in October, to the impacts of the pandemic and of the lockdowns on health in the city. And just to bear in mind really for other areas that you may want to look at, but we discussed previously really significant impact on mental health, the development of long COVID, an entirely new condition that we're just starting to understand. Changes in risk factors and behaviour. So smoking initially, there was a decrease in smoking, but we are aware in the most vulnerable groups that hasn't decreased. Alcohol, we are aware that there has been an increase in people who were already drinking, they're now drinking more, and also in obesity, and we know that information around childhood obesity, particularly, really significant impacts. We know that there was a change to NHS service delivery, a move to virtual delivery, and we know that there has been an accumulation of waiting lists because of the need to focus NHS care on treating individuals suffering from COVID and the challenge of having operations in the hospital at the time when there was cases in there. And we also talked previously around the Marmot review and the impact of the pandemic on health inequalities. So what Kirsty and I have done together is to have a look. And Kirsty, I don't know whether you want to say anything about these. That'd be helpful. Yeah, do.
Hi everybody. I probably know most people, but I'm, for tonight, Robin's sidekick, but I'm Kirsty McMillan. I'm a director in adult social care. So yeah, we just put up here, we know you've got an item coming up after we leave about your topic review, and obviously you've got a wide portfolio, but in relation to COVID and the pandemic, there are some areas that I suppose Robin and I would suggest might be of consideration, so that, you know, you've got to put it in the context of your wider topic reviews. Obviously, I think the chair mentioned the care home topic review, and I think we've had a couple of discussions at the board about why that wasn't taken forward. But that's not to say it couldn't be reconsidered or couldn't be scheduled at a later stage, which I think was one of the issues was about timing. So you might want to consider maybe revising the terms of reference, because I think at the particular point, the care home interest was about the experience of families and some of the residents, and that wasn't feasible at the time, but that things have changed, obviously, and there's lots of lines of inquiry to do with care homes, so that might be something. As Robin was just saying, the access to the NHS significantly changed during 2020, and lots of areas of activity ceased completely. And the NHS is very much in a restoration phase now, where they're trying to reopen services and catch up on waiting lists. But in particular, I suppose the layperson's more everyday experience is primary care, access to GPs. And I know that this board has previously had presentations about GP access. But there's other areas of primary care as well. That might be of interest. We haven't put it up there, but you could also consider all the kind of acute care, so operations, it could be something like that. In fact, the gentleman who was here before, Mike Hammond from the Royal Derby, would be probably quite helpful if that was something to look at. Obviously, at the moment, most of the NHS and our contribution actually is around the vaccination programme. And the specific area that Robin and her team, with some of my team's assistants, have been focusing on is not just the vaccination programme for the general population, but for sort of higher risk groups, to make sure that those areas of the population more exposed to health inequalities absolutely access the vaccination programme. That is a national requirement, but it's something we would want to do anyway. So it might be that you'd be interested in looking at how that's panning out. And then obviously more generally, what COVID has exposed is the impact of tackle, you know, if you don't look at health inequalities, sadly, the pandemic has exposed that's what often makes the difference in whether somebody survives, really. And as Robin said, that sobering slide about the deaths, you know, there was a lot of other factors that contributed to people dying. So just generally looking at health inequalities might be an area you want to focus on. But we, like I said, very much we've put these through with a COVID lens, and the board has got a wide portfolio, so you might not want to necessarily focus in on these, but these were just our suggestions.
Right. Thank you very much, Robin and Kirsty. I know you had to put that together in a short time scale, so that was very interesting. Does anybody want to put any questions? Councillor Foggett?
Just to ask about vaccinations for the younger ones, like the university up to like the 25-year-olds now. Is the university actually doing vaccinations as well and things like that, rather than us having, well, the NHS having to provide it all the time? Are they going into the universities?
So at the moment, the vaccination campaign is very much an NHS-driven and delivered programme. I think there's a question around what that might look like in the future, and currently, when young people go to university, the practice that they register with will check their immunisations, because there are particular boosters that they need for that particularly risky period of early days in university. So there are questions, I think, for the future as to whether that might be a good opportunity to include that within the basket of questions. But at the moment, it's very much centrally organised and delivered through the current programme. And I believe Simon Stevens, the Chief Executive of the NHS, did mention that they're hoping to progress to the 18 years and upwards imminently. So I think that's really good news. From a university perspective, they're just in the process now of young people starting to return home.
Thank you. Councillor Hussain just got in there before the others.
I'll try to be brief on this one because I think we're running a bit late. Part of the idea was to see what lessons could be learned locally to avoid repeating this mistake in future. But then, since then, to be honest with you, the more I've thought about it, I'm veering toward the conclusion that if in 5 years' time an unexplained infection was spotted or reported in Brazil, I think we would probably go through the same process again. In terms of, we'll wait and see until all the constituent parts in the virus have been identified to see what they do to us. Probably the Prime Minister will say, oh, it's okay, it's a bit of flu, I'm still shaking hands with people, it's okay, nothing to worry about, because you don't want people to go into a panic mode in your population. And then, I don't know whether the national review which has been conducted is going to look at things in much more depth. But thinking through it, I'm not sure locally in Derby we could things in place. I mean, unless you come up with something that we could say, well, at least this lesson must be learned, and we must trigger something to be in place much earlier than was the case, in particular if we think about residential care home residents. And in the earliest phase, we knew they were at risk, but we had no alternatives from the hospitals without being tested. We carried on sending them into care homes despite knowing, but what else could they have done, in a sense, because there was no alternative arrangement in place. You couldn't keep them in hospital because you needed those beds for new patients which were coming in every day in droves. I'll just leave that with you to ponder over, to see whether we have learned something that we could actually put in place to avoid the same level of...
And I think I would reflect again on looking at things through the lens of flu. And pandemic flu, from all previous experiences, impacts working age adults. Older people tend to have met a similar virus such as that, and although become ill, aren't so significantly impacted. And certainly in 1918, the pandemic flu, there were working age people dropping dead on the way to work. It was a significantly different group that were being impacted. And I think one of the key bits of learning is not to look at things through the lens of pandemic flu, unless it's pandemic flu. And just to have that step back and think, actually, are there different characteristics? Because I think nationally, we were very well prepared for flu and had exercised in 2009 on a response for flu. We knew what to do with that, we understood it, and this wasn't flu. And I think that's a really key part to that.
Thank you. Councillor Lonsdale.
Thank you, Chair. So you talked about sharing across different disciplines and different agencies. What I'd like to know is how you're going to keep that up, how you're going to embed that in our processes, so that just keeps happening, because that sounds like a really actually quite a good thing that we've learned through this.
Yeah, I think it has been absolutely key, and part of that is about those relationships, and there's a risk, isn't it, as time passes, that the people you previously worked with and that knowledge is lost. When I think from a public health perspective, we've now got relationships within parts of the council that we didn't particularly know that well, but also much broader as well. And I think particularly with the university, we've developed a very strong working relationship with the university, and also with the schools through the schools team as well. And I think now we have routes of communication and an ability to have early conversations about things that we didn't have before. Kirsty, I don't know if you've got a reflection on the care homes.
Yeah, I mean, I've probably met more people in the past 18 months in my working life than I've ever done in all the time that I've worked in Derby, because Robin's right, we were thrown together, but those connections, I think, have lasted, because actually when you're working with someone you never met before in a crisis, particularly if you're working with them virtually, although some of it was physically as well, you know, it's just very galvanising, I suppose. So I don't think those relationships will wane. Probably what is more challenging is organisationally that all the partners don't go back into their own worlds again. So quite a lot of the rules were stepped aside nationally. You know, there were new rules on information governance, for example. There were new rules on working time directives. So lots of things were sort of evened out so we could work together. And it's, you know, from July onwards, or whenever the date is, once all of that goes back to more of what it used to be, then some of those barriers might come up. But certainly, I mean, a good example would be, because Robin mentioned care homes, there's a lot of people surrounding the care home trying to support them, and in particular, the team of infection control nurses that are based up at Royal Derby Hospital. So even today, they contacted me to say, you know, we get lots of information about infectious diseases in care homes, things like scabies, or all sorts of things that normally I wouldn't have any insight about. Do you want us to start notifying you now about those routinely so we can build up that picture of what's going on? So even just now, those sorts of day-to-day contacts will just become more normalised for us. And it's how you can then bring all of that information together and then sort of relay it at a more strategic level. That's going to be the test, because that's when you'll get the learning, really. So yeah, I think we will stay in touch, definitely.
Thank you. And last but by no means least, Councillor Pegg.
Thank you, Chair. Turning back to vaccinations, would you say there is still vaccination hesitancy? And if so, is it more prevalent in certain age groups?
So we haven't got complete coverage of the vaccination. You know, we still have individuals that we haven't managed to reach, and I think we've got a working group that's looking at that, and we just need to reflect on why that is, because there's lots of different reasons why individuals don't come forward for vaccination, and it's not necessarily what we think it is. So I think it's really important that the group is communicating with the community and with community leaders a great deal in order to try to understand those issues. Because there's a temptation to think it's about physical access, and sometimes it is about physical access, but often there's much more complex reasons around that, around how confident people feel in the vaccine, or indeed how confident they feel in the services providing the vaccination. So I think the programme is doing incredibly well, and nationally it's doing incredibly well, locally it's doing incredibly well, and is probably so much better than we would have ever predicted in the uptake. We need to keep a close eye on the younger age groups, because there have been concerns that they may not be coming forward, although the initial responses that we've seen, certainly nationally, is that there's been a great enthusiasm to come forward for those vaccinations. But it's going to be an ongoing piece of work. We're going to be constantly and persistently looking at those groups that haven't taken up the vaccine and trying to find out why. And as I said, there's multiple different reasons and probably multiple different solutions to that. But it's just a continual effort, really.
Thank you. I just have just a quick answer, if that's all right, Kirsty, because I just know that it's getting very late. I mean, one quick observation. I think it's very interesting that I want to say only 16, but obviously each of those deaths is entirely tragic. But 16 out of the total number had COVID as the only cause of death. And I think that at another time, I'm sure you've already got a lot of thoughts on that, but I think that's highly noteworthy. And just very, very briefly, if you can, Kirsty, I'm just wondering what, if you're aware of you having to give particular sort of home care and social care needs to people, many people with long COVID. Is that?
Yes, that's probably a bit too early to say, if I'm honest. There is some long COVID clinics, I believe, being set up, but we haven't in social care as yet seen any increase in people presenting to us where that is something that they're suffering from. But anecdotally, we are hearing of that. But I'd say certainly from a social care point of view, it's not coming through as yet.
Right, thank you very much. So, yes, Councillor Hussain has one last burning question.
It's just to wind it up in a sense. I mean, obviously you're going to do it. I'm just wondering whether we could ask Robin and Kirsty to make one recommendation to the council, saying next time if we are hit with a similar phenomena, please be ready in this way. So at least we get something out of this topic review to pass on to the council as a recommendation, saying, well, as a result of doing this topic review, we've come up with a recommendation which should put you on alert in certain ways so we can get in a ready position much more quickly next time.
Robin? Thank you, Councillor Hayne. I agree with that. I mean, that's really where we need to be getting to, because what has happened has been tragic and difficult, and it's affected everybody. And hopefully we don't want to see that again. But what is really vital now is that we do learn the lessons, we do learn things, and we do our utmost. Although history doesn't always repeat itself in exactly the same way, so it is difficult. But I totally agree with that. So if that's something we could both reflect on, and I am going to wrap that up now because we are running very late. But I'd like to thank you both very much for your input tonight and for all the work you've done over the last very difficult and often traumatic year. And we look forward to working with you both again on many of these areas, I'm sure. Right then, so very quickly then, we just need to look at a work programme and topic review. I mean, you won't be surprised to know that I've had a look at some of this and I've got some ideas. But before I speak, with regard to the work, well, let's think about the work programme to begin with, shall we? Do you want me to list the areas that I've thought about and you chip in afterwards? I know you probably might want to fine-tune them, or maybe we'll just do it as an agreed general area at the moment and then try and fine-tune it out of the meeting or whatever. But so basically, actually, Councillor Lonsdale has already suggested this, if you don't mind me speaking on your behalf, and it's the issue of dentistry, NHS dentistry in the city. But we all know, it doesn't need to be said, that NHS dentistry is now the absolute Cinderella, if that's the term, it's one of the Cinderellas of the NHS service. And also, so we want to look at that. We want to perhaps look at how it's been, access to that has been affected by COVID. Diane?
Do we know actually how many NHS dentists
Well, these are the kinds of things we need to ask, and I'm aware that I've been told that come September they'll transfer to this new integrated health and social care authority. So we want to be mindful of what impact that's going to have. So we need to know exactly what is available, and also how that has been, the problems around accessing that have been accentuated by COVID. So we're all happy perhaps to look for a report on that in October. Yeah. I think NHS waiting lists, how those are being managed, and yeah, is everybody Farid, you happy? Yeah, this is for the work programme. So this is stuff we'd have on, just reports on. We can look at the topic review first if you want, because I have a thought on that. Okay, let's okay.
Let me make a suggestion that we look at GP appointments as well.
GP appointments.
See where things are, because I think it's impossible to get a GP appointment. I mean,
Yeah.
I can also tell you that I could be on 33 times before I could get through to speak to somebody, because the waiting queue was that long. The minute I stopped dialing, I got cut off.
Yeah, it's totally. And if you were calling, whatever reason you're calling, if you're calling for mental health issue, it's desperate, isn't it? But Councillor Froggatt?
Yeah, I think we definitely need to know when the GPs are going to resume a normal service of, proper face-to-face, and restart the online appointments, because you still can't get online appointments yet. They're still not they're supposed to be letting them out.
Okay.
NHS England said that they were, beginning of the month, supposed to be bringing out the online appointments, but I've not seen a GP service yet that's put it out.
Well, our next meeting, of course, is in October, sadly. That's a long way away. But we could try and commission a report on that for the next meeting then, as those are kind of pressing concerns now. Yeah? So we'd have a... I mean, we can look at...
From last year's experience, we get bombarded with mental health trust and acute sepsis trust. And most of those reports are actually for local. We could get the view that we have a quick look at those reports. They can see, but it's our area of interest, the complaints that we are getting from our constituents, from constituents.
Yeah.
Also, appointments, etc. We want to be asking for at least 2 reports to be covered in each one of our future meetings. We can cover 7 or 8.
Yeah, I agree, and I did defer actually to reports this evening, just for noting, because of that, because we do have a constitutional responsibility, as you know, towards the NHS. So other issues that we may have on the work programme then, Councillor Lonsdale?
It would be quite good to have a review of services in some description for adults with learning difficulties and, and social service interaction with them as well.
Okay, thank you. Councillor Pegg.
Really, from tonight's meeting, as Councillor Froggatt said earlier, could we in some way scrutinise or find out the processes for scrutiny and monitoring of home care services to see that the standards are being maintained?
That's once all visits. We can.
Yeah, that was on my list as well, because I know that the funding for that is rock bottom, and the support for the voluntary thing for that has gone as well. So, yeah. And Councillor Froggatt, did you have something else? Okay, yeah, we can ask for that. Okay, that's any good specific kind of question. We've got one of the huge, I mean, this is huge, so we may need to, we will need to fine tune this, but another area that I think we just has to, I'm sure it's been addressed before, but we have to keep addressing it because it is so important, is obesity, and it's adult. I mean, obviously we're responsible. So adult obesity and strategies to deal with it. I know none of that's new, but it's something I'd like at least to potentially flag, just to keep the focus on that. And oh well, there's so much more. There's mental health, post-COVID response. Well, we can organise an extra meeting if there's an appetite for it. I thought if I suggested that to Lindsay, you'd all moan at me, but do we have an appetite for that in theory?
In theory, yeah.
Okay, that's something we'll look at then. Thank you, Councillor Froggett. Any more suggestions? This is not exhaustive now, but any more suggestions now for a for our work programme? We can bring. You're right, Councillor Hussain. When something comes up that we know, in fact, you got the dentistry thing through contacts in your ward, didn't you? Then we need to feed it into here. So I think that's what we should do. So coming to the topic review, I'll just express my view first of all, and then I want you to tell me, obviously, your views. I have looked at the topic review that was attended for last year and the scope and the terms of reference, and I actually thought it was very good. I have talked to officers about what they didn't do on that, why that didn't happen. And I have had other suggestions, and I was initially thinking that perhaps we should do a different topic. Possibly the dentistry because it is something that is rarely looked, it's often overlooked, and I was kind of really keen on that. But the more I thought about this, and the more I've talked to officers, and the more I've looked at the situation, I think I personally would be inclined to return to perhaps as you said, reconfigured slightly, given that we're now care home topic, because we need to know from a local perspective what happened in care homes. And as Councillor Hussain said, it's all about learning for the future, and that was a key area that was going wrong in the first part of the pandemic. And so, why did it go so badly wrong? Or maybe it didn't, and we need to see evidence that it didn't go wrong. But that is something I'd like to look at. So, any views on that?
No, I'm interested to know why happened.
Yeah.
As am I.
Yeah.
We're not going to FaceTime because of people.
Yeah. Yeah, and we will, because before, obviously, as Councillor Hussain has explained, we didn't, you proposed that, and then nobody initially anticipated the problem, the pandemic continuing as it did and the way it did. And we know that it won't be over by Christmas, even this Christmas. But what we can anticipate, bearing in mind that we've got, till potentially next March to interview certain kinds of people, that I think there will be windows of opportunity to interview the kinds of people that we'd like to interview. So we're all agreed on revisiting the care home issue in some form. Yeah, that's brilliant. Thank you so much for that. And as I said, if you've got other suggestions that you want us to look at, just say and get in touch.
Is the provider, what have they got in place to monitor the quality of the service that's being given? And what do they do about it?
Kirsty's going off path, but she tells me about once more.
Yeah, okay. Right, thank you. Yeah, it's a really good point. Yeah, thank you. Okay, so are we okay for that for now? As I say, we can revisit it and I'll be looking for views and more detail about how to angle these reports. Okay, and finally, we just have, just for note, which I did defer to another meeting because I thought this one was too packed. We have a report on the Sinfin healthcare development. And we should be receiving as a report at the next meeting. Okay, if there are no further comments, then I will close the meeting. Thank you very much for attending. Thank you.